Great to see you,
Thank you for
Eric.
having me here today. Good morning to all. It's good to see you guys. I do have so many fun memories of my time at county. For those that are in residency and fellowship, please enjoy yourselves over there. You're gonna miss working over there when you leave. And so I will say that when I arrived at county, when I was immersing myself in the ultrasound world, I was not thinking what I was gonna do with that. I was not thinking, hey, what's gonna be specialized, what's gonna be my forte or anything. It just came by being in one of those shifts that we had a sickle cell, had to measure spleen and everything, and I went like, "Hey, this is something that I myself think that I could integrate both of my fellowships together and try to educate more and more about integrating ultrasound in the pediatric world." And that's the reason I call it the final frontier for pediatrics, because truly, when you compare both the adult world or the pediatric world, you're going to be seeing that obviously we apply ultrasound more and more and focus more and more in the adult side. But when I started doing fellowship, it wasn't as common in the pediatric world, but we have been able to start also immersing ourselves into that world and bringing that technology more and more to our patients in the ED, in the floors, in the ICU. So we are finally achieving a level that we're going to be at the same level that the adults, and I'm really happy about that. That's what I call the final frontier, because we're already crossing that border and achieving what we always wanted to do. So I'm going to be talking today a little bit about pediatric ultrasound, a little bit of some modalities that we're going to be using, discussing how can we get good imaging, good techniques for image acquisition, integrated both in the diagnosis and management of pediatric patients, because we got to understand that the different modalities that we can be applying have their limits, right? For some patients, we can rule out disease. For some patients, we can rule in the disease and therefore manage the patient accordingly. It's a game of sensitivity and specificity, understanding that the ultrasound answers clinical question. The first thing for any ultrasound is asking ourselves the clinical question. What are we going to try to answer? And my next question is going to be, in my case and the case of all that are in the pediatric world or in the ultrasound world, does ultrasound help me to diagnose or manage this patient? And if the answer is yes, by all means, integrate it into your practice. If at any point during the presentation you guys have any question, just let me know. I'm happy to answer them. I like to tell people that I don't do presentations, I do discussions. Let's have the debate, let's have the discussion. So please let me know if you have any questions. So, what are the role of POCUS in pediatric emergency medicines? First of all, we are going to be seeing a live real-time visualization of anatomical structures. And what does this mean? This is the main difference between POCUS and X-rays or imaging. Imaging is a static picture, right? It's a picture of a moment, while the ultrasound is a live image of what is going on. And that integration into our clinical practice helps us manage the patient better, and also helps us to create a great rapport with the parents or caretakers when we manage the patients, because they're seeing that we're there, they're seeing that we're caring for that patient. It avoids painful procedure. It decreases the uses of sedation, which we're trying to do more and more to decrease those things in the emergency department, and the unnecessary use of those things. Although sometimes sedation does help to acquire imaging, but it's not the main thing that we do. And also, obviously, we're dealing with a pediatric patient, right? A pediatric patient has rapid developing tissues, has a rapid cell turnover. So they are more prone to having side effects from the radiation of CTs or X-rays. So by using the ultrasound, we are decreasing that exposure of those developing tissues to ionizing radiation. So I'm going to give you the tips for getting a good focus on a pediatric patient. And I always emphasize this to my residents. What is the question that I want to answer? Basically, I want to answer the question, does this patient have appendicitis? If my pretest probability when I'm doing that just thought of analyzing that patient has it, my next question, does ultrasound help me in the diagnosis? Yes, that is correct. Then I integrate it to the patient, because just doing ultrasound in a random way, it's kind of it kind of brings a little bit of trouble and problems, because it's not to be used irresponsibly. With great power comes great responsibility, right? So it's the same thing. We got to answer that question. And always, always try to use, and this is something that sadly I don't do as often, A lot of EDs do have the warmers, and we still don't use them. We need to use those warmers, particularly for our pediatric patients, because all the gels caught all the cold air from the ER, from all the AC on, and it's really uncomfortable for the patient. So warm gel goes a long way with these patients. And use the parents. Please, people, this is the way to acquire a great rapport, not only with the patient, but also with the parent, because you're integrating them to the examination, you're integrating them to that evaluation, and they soothe this. There's no better way to soothe a child than having the parent help out with the procedure. You gotta do it while the child is lying on the lap of the patient, and you can, the parent, and you can do the ultrasound that way. It goes a long way. So please use the parents. And also, very importantly, we're not painting a room in our house. This is not heavy strokes. We're going to use fine adjustment, fine movements, just a little bit of rocking, a little bit of fanning, or a little bit of rotation goes a long way of these patients. So very, very fine tuning, because you don't have a large superficial area in most cases. So you need to do some fine adjustments to acquire a better image. Okay. Let's start with what I think it's one of the main categories, if not my favorite one, when we're doing focus in a pediatric patient. We start with a 4-year-old that comes to the ED, 5 days of cough, fever, comes from an urgent care, or what we call in Puerto Rico, the CDTs, the local clinics. And they did an x-ray and they sent it to the ER because it has this report. It says this could be atelectasis versus infiltrate versus consolidation, findings may be viral infection, bacterial, please correlate clinically. And you are like, thank you very much. You said nothing to me. Some people would just go, well, because of the read, maybe I should start antibiotics. Again, we gotta be responsible. We gotta choosing wisely campaign, right? We don't use antibiotics as just because of it, just because of findings. What is the clinical picture? What is going on? And using this X-ray as an example of what we get from when we send these patients to the clinic, I got the first set of bad news for you guys. And it's basically that X-rays suck for the diagnosis of pneumonia. When we look at the data, X-rays are like 40% sensitive, and they're still like a gold standard for us in the emergency department. And that is okay. I've been taught that. A lot of people are being taught that. We catch up really slow sometimes. But we need to understand that this is not something that is just being said now. It's been said for the past couple of years. Like in 2019, the Infectious Disease Society of America said in a statement that the widespread use of ultrasound will eventually need to replace X-ray because it has a bigger sensitivity, like 70% or 70 something for catching pneumonias in comparison to chest X-rays. So this is the first thing that we got to understand, that X-rays have their limitations, and the integration of focus in the pediatric patient is essential or vital to ruling out the pneumonias. Why? Because it has good sensitivity, not only detecting a consolidation, but it also can give us information about the probable consequences of a pneumonia, like, for example, pleural effusion. When you see the comparison, 95% of specificity for ultrasound versus three-fourths or 75% good for X-rays. I mean, come on. Obviously, ultrasound is winning in this case. So we need to integrate better, and it also helps us to differentiate it even more when compared to when we're trying to evaluate for atelectasis and other things. Now, let's start a little bit about technique. How am I going to be doing this? And as I said before, we're having a kid. A kid has a low superficial area in comparison to the adult. So I'm thinking most cases I'm going to be using a linear probe, most of the cases. Sometimes, obviously, if the kid is a little bit on the chubby side, or is an older kid, then we can start using other probes, such as the phased array. In particular, the phased array will be really good for these cases because the kid has a lot, their rib cage are not as prominent. They don't have that much intercostal spaces. So you need a probe that can navigate more in the area of the chest. Now, there's different ways to do this. Some people split the chest in 3 areas. I myself do it in like 3 areas each side. I myself do it splitting it up like in 8 areas in the anterior chest, particularly in the anterior chest. So I go mid-clavicular line, upper chest, that's my zone 1. Then when I go closer to the nipple level or a little bit lower, that's my zone 2. And then I go mid-axillary, up all the way closer to the axillary, that's zone 3. And then when I'm trying to see more like the liver interaction with diaphragm and the base of the lung. That's my zone 4. And I'm going to be transversing that area like this. So I'm putting the probe in a longitudinal fashion, which means we're going to put the marker on the marker to the head of the patient. And then we're going to do a sweep of those areas. And we're going to do that also on the left side of the chest. Now, on the left side of the chest, we know that we have the heart. So when we have the heart, we can move a little bit more laterally to try to capture the lung that is located in that area. But also, we can carry the patient or use mom and dad to carry the patient and also evaluate the area all, surrounding the scapula, right? Or also evaluation of the posterior area. I usually don't divide that in zones. I just swoop and evaluate a little bit at the margins of the scapula and then go below the scapula and evaluate the patient there. And that way I can see evaluate and do a good evaluation of the lung. Now, the image on the right, you can see a normal lung. Basically, the presence of A lines, which I'm going to be discussing in the next slide, tells you that this is a normal lung. Now, what are A lines? A lines, they're always defined as a reverberation artifact, which basically means that when the sound wave uh, impacts the area of the pleura. Sometimes it starts like bouncing up and down in between the probe and the pleura. And then what you see is that equidistant to your probe, to that footprint, from the probe to the pleura, you'll see below the pleura in the same distance and hyperechoic line, which is a representation of that pleura, basically because it's bouncing up and down. This ultrasound is interpreting that there is another echogenic structure below the pleura. This is really important. The enemy of ultrasound is air. So when you're evaluating the lung, you have an aerated organ. So what the ultrasound is doing is not evaluating the parenchyma. What the ultrasound is doing is taking that information and translating it into what it thinks it's the physical form or the way that it looks, the lung looks because of the presence of the air. So if you are seeing parenchyma of the lung, which basically looks like the liver, that is pathological. That means something is off because that means there's fluid accumulation, there is inflammation accumulation, because what we need to be when we're evaluating the lung, what we need to see is this image, which is basically the ultrasound interpretation of an aerated organ. If that is normal aeration, what we're seeing, but as we get pathological, we start seeing parenchyma and start seeing anechoic presence of other artifacts, etc. So, what are some of the pneumonia findings that we can find? We can find focal B lines. We can find subpleural consolidations. We can find consolidation itself, which I said is basically the parenchyma, visualization of the parenchyma that looks kind of like the liver. You can see bronchograms, which is the presence of air trapped by fluids surrounding it. Oh, we can see effusions. And basically, I'm going to discuss each and every one of them. Most time, most of you have seen this when we're doing focus of a patient that we think has edema or we think you see a chef as the cause of symptoms. We see the B lines. Basically, the B lines are lines because of fluid getting stuck in the area of the interlobal septa, which is causing a sort of reverberation effect. And what it does is that it goes all the way from the pleura, goes all the way down, and it erases my A lines. So it is pathological to have this. When we have in our pediatric patients, how can we apply this? If we have a patient that comes in with cough, with fever, we're thinking pneumonia, and we evaluate the lung, everything looks good, but there's a certain area that is showing the presence of B lines that can be revealing, or it can increase the probability that we're having a pneumonic process in that area. Another findings, we gotta be careful with that. I gotta say, when we're evaluating for B lines, because it can be a huge amount of things based on the differential diagnosis, and that is why it is important to try to, when we evaluate a patient, understand the concept of my pretest probability. Basically, what's the probability of this patient having this certain disease? Because in itself, the presence of B lines doesn't tell you that the kid has pneumonia. If the kid has other diseases, other conditions, or for example, CHF, congenital heart disease, etc., you can see B lines in the presence of edema. But if I see it localized in a patient that healthy kid, vaccinated, has a history of cough for 4 or 5 days, but well, it increases my probability that it's a pneumonia. But it's not pathognomonic. What is going to be pathognomonic are some of the findings going to be showing you in future slides. Now, as I said before, the lung is the ultrasound, when it shows you the image of a normal lung, it shows you the interpretation of an organ that it has air inside. When you're seeing parenchyma, as you can see in this picture, we see on the right hand side of the picture here, we can see the liver. But then when I look at the left hand side, I see kind of like not like a same similar structure. This is called hepatization. And it's basically the visualization of the lung parenchyma, which tells me there's fluid, there's an inflammatory process, if there's something off going on. However, in a patient that is really a little healthy, but having maybe some shortness of breath, not necessarily having fever or cough, this can also be seen in some cases of severe atelectasis. However, as I said before, what's your pretest probability of pneumonia? Ask yourself the clinical question, because if the probability is high that this kid has a pneumonia, odds are that what we're seeing here is not atelectasis, it's a consolidation. But what is pathognomonic of having a pneumonia is having air bronchograms, particularly what are called dynamics. Now, there are two kinds of air bronchograms. Those pathognomonic, which is the dynamic air bronchogram, but we do have also what is called the static air bronchogram. And the difference is the following. If you look at the picture here, you're going to see several areas that look echogenic, right? That look really bright in my picture. That is air. That is air that is trapped in the bronchioles of the patient. And what is going on is that because the air is surrounded by fluid, you're able to kind of like visualize that entrapment of air. That is what an air bronchogram is. And it defines really well that bronchial or bronchial structure. When we don't see it, that it moves with the patient's respirations, that is called static air bronchogram. That can happen in atelectasis, although it can happen in pneumonia. It's not pathognomonic of pneumonia. What is pathognomonic of pneumonia is like you see here in the picture over here, you see that there's like a movement up and down when the patient is breathing. That is called dynamic air bronchogram. And of all the findings that I have discussed in the past few minutes, this is pathognomonic for a pneumonia. It is a dynamic air bronchograms is an air bronchogram that moves with patient's respiratory rate, and it distinguishes it from atelectasis because if you have just a bronchial obstruction, it's not going to be moving. And it's because the movement of the fluid inside of the lung parenchyma, what is leading to the presence of those dynamic air bronchograms and making it pathognomonic for pneumonia. There are other diseases besides pneumonia that we can diagnose in patients with shortness of breath and respiratory distress coming to the ER. For example, 6 months old comes to the ER, has fever, a lot of mucus, and when you auscultate the patient, it feels like there's some kind of washing machine inside of the patient, which obviously tells us most that this is a bronchiolitis. But the kid has been having high fevers, low SATs, although the evidence is there that we don't get as often pneumonias with bronchiolitis. Some parents may not be comfortable you telling them, oh, this kid has a bronchiolitis, I'm not going to be doing an x-ray. And that is okay. The way to try to develop that report is integrating focus into your evaluation. And in patients that have a bronchiolitis, what we see here in the ultrasound is kind of like this appearance in which the pleura is very, very thickened, but it also has this area of anechoic interruptions of the pleura, which is basically very small, very less than a centimeter subpleural consolidations or effusions. And it kind of gives an appearance of a road that has a lot of potholes, but a resident of mine call it like the lumpy bumpy appearance. Kind of feels like that. Like you can go and ride a car over here that is gonna be crashing in those potholes. That is very pathognomonic of having a bronchiolitis. So basically, for bronchiolitis, you're gonna be seeing some B lines, as you can see here. The irregularity of that pleural line, those subpleural consolidations of less than a centimeter, points towards the diagnosis of bronchiolitis. And when we do have those findings, and a parent that wanted to be able to feel comfortable that his child doesn't have a pneumonia because he read somewhere in Google or saw on the PID or any other TV show that a kid with respiratory distress is a pneumonia, we just tell them, look, this is the appearance, this is a bronchiolitis, we're going to be giving suction, we're going to give him oxygen, and we didn't give unnecessary antibiotics in this case. Now, Let's go 1 second. Let me see the chat over here. Okay, so I got another case for you guys. I wish all the cases that I got in my ER for belly pain were this kid. So basically, I got an 8-month old, 8-year-old kid that comes with no past history to the emergency department. Mom states that he has started vomiting yesterday and then at night started complaining a lot of belly pain. Then when he arrives here in triage, he has 39 of fever. His pulse is elevated, although he's breathing really well. And now he says that the pain was started on the navel and then moved towards the right lower quadrant. I wish that every patient was like that. Obviously, we're talking about appendicitis, but what I wanted to let you guys know that obviously the presentation that this patient is having gives me a high pretest probability that this kid has an appendicitis. So as I said before, what's my next question? Does ultrasound gonna be helping me to diagnose the appendicitis? Yes. But in particular, what studies have shown, we're gonna be discussing the limitations of this study, I mean of the ultrasound therapy, what the studies have shown and what new literature has been showing. So let's start first with evidence, technique, and anatomy. So my first question, how accurate is POCUS for diagnosing acute appendicitis? From Kings County on 2017 came an article of 4 meta-analysis from the American Academy of Emergency Medicine done by Dr. Benabas and Dr. Steiner and Dr. Shaw, in which they took 4 meta-analysis and so 4 studies in their meta-analysis from moderate to high quality and evaluated 461 patients, in which POCUS had a sensitivity of 86% and a specificity of 91%, which translated to a pretest probability of 9, where it was a positive likelihood ratio, a positive likelihood ratio of 9.24 and a negative likelihood ratio of 0.17. So basically, what we found in the study and what we're saying is that as emergency physicians are able to uh, to rule in appendicitis. But if the focus is equivocal or negative, ruling out is not as good. The ultrasound is not as good. So if we don't see it, that doesn't mean it's not there. If we see the non-comprehensible appendix of more than 60 millimeters, it tells us that this is appendicitis, that this is the diagnosis, and we don't need to do further studies. However, I need to do a caveat here, because new literature has shown in the past few years that integrating a negative ultrasound with a set of other markers such as CRP, white blood cell count, how the patient is doing, etc., may translate in future follow-up of the patients that in fact didn't have appendicitis. However, more literature, more studies have to be done prior to that to be standard of care. But watch for that. Stay tuned, because I think that we're going to be moving to integrating more labs and maybe a little bit more clinical gestalt or developing scores in that way when an ultrasound may be negative. So let's talk a little bit about the technique and anatomy to understand how we're going to be using the ultrasound in pediatric patients and what are we going to be performing. So our weapon of choice for this case are going to be 2 weapons of choice. The first one, as I said before, dealing with kids. Since we're dealing with kids, low body surface area, we're going to be using the linear probe. However, older kids, pre-adolescents, chubby kids, we're going to be using either the curvilinear or the phase array. Whichever one you prefer, whichever one is your preference. However, I myself prefer the curvilinear. Why? The curvilinear has more surface area and I can cover a little bit more right lower quadrant when I'm using it. So the technique is going to be that we're going to be placing the patient in a supine position, and we're going to try to identify both the psoas and the iliac vessels. And the appendix is going to appear like a blind end pouch in that anatomical region. And we're going to be applying and doing it in a lawn mowing technique fashion. What is the physician doing in this case? What he's doing is applying the ultrasound probe in a lawn mowing technique, in which basically covers the entire right lower quadrant region, and then doing graded compression every centimeter on and off to try to see and look at structures that may not compress while you're evaluating the patient over there. After finishing up with a transfer view of the right lower quadrant, we're going to be doing also the lawn mowing technique and graded compression every centimeter using the sagittal position and identifying, importantly, the second, particularly in the long axis, because if we see a structure that is non-compressible, we're gonna try to trace it to the cecum. The cecum looks on the ultrasound kind of like a triangular kind of shaped structure in which the blinded pouch is gonna be ending if it's identified as the appendix. As I said before, identified as psoas muscle is going to look like a striated structure that is going to be on the right side of the patient with the iliac vessels that are going to be showing and that you're going to be demonstrating that you are located there, not just by the anechoic presence, but you got to put a little bit of color flow. I always start when I start doing appendix studies, I try to do two things. I try to start at the point of maximal tenderness, and or I try to show this picture of having the iliac vessels identified and the psoas, telling the others that are going to be seeing my ultrasounds in QAs and other physicians that I'm in the psoas region and in the iliac vessels region. Now, I said that we're going to use graded compressions until those landmarks are visualized, because we're going to do graded compression. The reason we do that every centimeter on and off is because we're trying to move the gas and bowel out of plane to try to bring that appendix more closer to the screen, and also visualizing the compressibility of the structure that we think is the appendix, because if we're thinking about appendicitis, it has to be a non-compressible structure. Over here in this image, they identified the iliac vessels, identify a round structure that they think is the appendix. When we are in a transverse view, most appendices are going to be seen like a circle, kind of like a target sign. When we are in longitudinal view, we're going to be seeing the appendix more in its tube-shaped appearance. Now, a normal appendix can appear in the ultrasound, and it's going to be one of those instances if we can readily say that we're excluding appendicitis if we have normal findings for the appendix. Basically, the appendix, when it's confirmed, you gotta have to visualize it both in transfer, like in this form, in this image, and then also in a longitudinal way. And it should be a blind and tubular structure that measures less than 6 millimeters. If you find that an appendix, and it's kind of like a little bit more compressible as you see in the image, you find it, and the diameter outer to outer is going to be less than 6 millimeters, that is a normal appendix, and you could exclude appendicitis. Although most of the time, this is really important. If the patient has pain in that area, even you see a normal, if you start seeing inflammation, edema, things that I'm going to be discussing right now, this could be an early appendicitis that we're catching, and this patient needs to be consulted to surgery. So be careful with that. So let's talk about some of the findings of appendicitis, and we're going to start first with the most specific findings, not the secondary findings. If we are suspecting, we find a structure in the area of the right lower quadrant that is a blind ended structure with more than a 6 millimeter diameter, outer to outer, not inner to inner, outer to outer diameter, that when you evaluate at a longitudinally transverse, you evaluate and it traces all the way to the cecum, that kind of triangular structure that I described before. Non-compressible, unless you're thinking perforation. I'm going to be telling you some secondary findings of perforation that has no peristaltic activity and that has a target shape in transverse, that is diagnostic of appendicitis. You have the diagnosis, you don't have to do any further studies. And when we're talking about a target shape appearance of the appendix, what we're talking about is that it's going to be in a way that has anechoic fluid filling the lumen, because of all that inflammation that is going to be surrounded by a very echogenic, meaning more whitish mucosa, and that when we apply color flow, you're going to be seeing that it's going to be showing a lot of flow because of all the inflammation process that is happening. This is a case that we had in our ED. You see over here a blind end pouch that is non-compressible, non-peristaltic. In our image that I don't have here, we trace it to the cecum and we were able to trace it, and that has some air inside, but you see no peristalsis in it. This was diagnostic for appendicitis. Kid was taken to the OR with this ultrasound. No need for further studies. The pediatric surgeon came down and took the patient upstairs to the OR, and the patient had a good recovery and the appendix was removed. Now, let's talk a little bit about other secondary findings of appendicitis. There are secondary findings such as free fluid surrounding the appendix. We can see areas of extreme edema, which is going to be very echogenic. We're going to see fast stranding, which I'm also going to be showing, and we can see signs of perforation. And perforation is important. We're suspecting it. When we suspect perforation, when we have fluid, and when you're having a structure that is kind of like entubular, but that kind of compresses, not necessarily that means that the patient has doesn't have an appendicitis. That can be an appendicitis because the appendix perforated. So if the patient has a lot of pain, or that the patient in fact had resolution of pain, had a very, very intense pain that it kind of felt like something like pop, or had a full resolution of pain, or some resolution of pain, be careful because that can be perforated appendicitis, and this is one of the findings that we can in fact identify. This is an image in which we see a very thick and hyperechogenicity of the overlying peritoneum over the appendix. This is a secondary finding of appendicitis, not one specific one. But if you see this, it kind of, in the right lower quadrant, an area of very echogenic hyperechoic material, look for the appendix because it got to be there somewhere. That means that there's so much edema going on in the peritoneum and so much inflammation because of something that's going on over there. And the other thing, as is a secondary finding, is an appendiculate or a ficulate. Basically, the presence of a very dense structure, such as like we see in the gallbladder, like stone, etc., in the area of the tubular structure, at some portion of the tubular structure, mostly it's distally proximally in the structure, that is also dense that it generates shadowing. And it's because of the presence of that ficulate in the base of the appendix, and it's a secondary finding. In this image, in fact, you can see a little bit of also fluid accumulation, edema. You can see it over here, free fluid in the area. Very, very hyperechogenic peritoneum also. So that shows fast trending. So we have findings that are primary findings and secondary findings for appendicitis. Let's continue a little bit. Now that we're in the belly, let's continue with the belly. We got an 8-month-old comes to the ER. Dada mom gave some food at 9 p.m. and then around 12 a.m. started vomiting 4 times. Mom became concerned because she's seen that he's less active than usual. And they were describing that he cries, and then it feels like he just stops completely and lies still. And then mom comes and also shows that this morning before coming in, I'm sorry, he had a diaper like this, which what we can describe as current jelly stool. Now, we all know the diagnosis is C-section, but let me clarify something. If we're up to this point and we're seeing current jelly stool, we're late in the game. Although it's part of the triad, that means that there's some ischemia the of the intestine, of the bowel, and that is concerning for the fact that you may not be able to reduce it using air enema or any other measures, then they may require OR reduction. Now, I'm going to be showing you how the ultrasound can help to see if the reduction is going to be successful or not, depending on certain findings. And we're going to see how we can integrate the ultrasound not only for diagnosis, but in this case, in introduction for management of the patient. Now, intussusception is basically that invagination of a segment of the bowel inside another segment of the bowel. And the most common one that we're going to be seeing is the ileocolic one, basically insertion, small bowel inside the large bowel. It occurs more frequently in kids that are 6 months of age to 2 years of age. And we see it more in male patients than in female, with a ratio of 3:1. Ultrasound is really accurate. It only has, in comparison with appendicitis, a good specificity, but it has a good sensitivity. It's one of the best ultrasounds for sensitivity and specificity. So basically what I'm saying is that if you see the pathology is there, but if you don't see it, odds are that it's not there. Why? Because most of the time are ileocolic. As is there ileocolic, literally you got an invagination of the small bowel inside the larger bowel. So the large bowel is a very big organ. You're able to see it. The ultrasound can help to distinguish some pathologic lead points. However, most of the time we don't really see that. It's really idiopathic. We don't know the cause, etc. But also helps us to detect what some features that may indicate that there is a higher probability of failure in reduction. Why? Because when we apply color flow, we're looking to see if the bowel has presence of knob of adequate blood perfusion. And if we don't see that using color flow, that tells us that there is a higher likelihood that there is no flow of blood of adequate perfusion to the bowel, and therefore there is a lower chance of reduction by the radiologist in comparison to OR reduction. Other things that we can see to that may increase the risk for failure for reduction include trapped free fluid, intramural air, or lack of dissolvent flow, as I described. Typically, in intussusception, you're going to be seeing like a 3 to 5 centimeter structure in diameter, and it's really, as I said, recently identifiable because of it. Most cases happen 6 months to 2 years of age. So our probe of choice is going to be the linear probe. And we're going to be doing something similar to the appendix study. We're going to put the patient in a supine positioning, and we're going to be doing radicular compression. Now, I always recommend when you're doing an intersection study, don't only rely on looking on the right upper quadrant. There can be shifting of structure. It is a kit, it is a very small surface area, so you can do graded compression and evaluation of structures all the way from the right lower quadrant to the right upper quadrant to the left upper quadrant to the left lower quadrant. So when I do an interception study, I do it all around the belly, dividing it into the different quadrants, and I get both sagittal and transverse views of the different quadrants. If I go to a right upper quadrant on a patient that has a presentation similar to what I had in the patient I described before, this is what I'm going to be seeing if he has intussusception, the famous target sign appearance. And I'm going to be describing it now. Basically, what we're looking at is the presence of bowel invaginating in the area of the larger bowel with surrounding edema and also edema around it. And you can see sometimes even a little bit of fat surrounding that increases and enhances even more that target sign appearance that it has. We can do, as I said, transverse, but also we need to do and confirm with longitudinal. And in longitudinal views, not only you will be able to see, you're not going to be seeing the target appearance, but you're going to be seeing that invagination of the small bowel, in most cases, into the larger bowel that confirms that intussusception is happening. As you can see here, we go to transverse, we go to longitudinal, and you see that small bowel entering the larger bowel over here. Once again, a target view followed by the longitudinal view. Very important, that hyperechoic center, which is basically let me just start again. The hyperechoic center, which basically is the small bowel, has pulled a little bit of the peritoneal fat surrounding that bowel inside into the larger bowel, which gives it the characteristic target shape appearance. And you see that the large bowel can be a little bit more hypoechoic, and it's because it's very edematous, it's filled with fluid, and it can have even some fluid surrounding it outside of their walls. Sometimes it is described as a pseudokidney, and you gotta be careful with this because in the right upper quadrant, some people may say, "Oh, this is the kidney." When you compare the area of the intussusception to a kidney, you may see that something has appearance of the echogenicity of the renal pelvis, and that's the reason some people call it pseudokidney sign when they identify intussusception. So, what you can do with that to don't anchor yourself in the diagnosis of intussusception. If you identify a structure you think is intussusception, make sure that you also identify the kidney to try to exclude the possibility that you're seeing the kidney or just relying yourself that, oh, this is the kidney. So be careful. Gotta see those two structures. Be careful anchoring yourself in either one. Okay. So what does the literature has shown? That if we apply, when we get those images in transverse or in longitudinal, go back to transverse, get that color flow. And if we don't see flow like what we're seeing here in this picture at all, that tells us that the patient doesn't have adequate perfusion in the area of the intussusception and therefore has a higher risk of having inadequate reduction when we send the patient for radiology. So you gotta involve pediatric surgery early on. When I have my case in intussusception, I'm suspecting or I have the diagnosis, I don't only involve radiology, I also involve surgery because you want them both on board in case that radiology fails in the reduction and surgery is already aware of the case and a way it can manage the patient faster and avoid ischemia to the bowel. Okay, we're finishing up. We got this 4-week-old male patient. Mom said that started vomiting this afternoon. Vomiting is described as a projectile vomiting, but mom states that most of after those episodes of vomiting, the kid starts crying like he's hungry, like he keeps eating, and that is very particular for the cases of what hypertrophic pyloric stenosis. It is the most common intestinal obstruction in infancy. in infancy. After infancy years, toddler years, and even some preschool years, intussusception is the most common cause of intestinal obstruction. There is a 4:1 male to female ratio, and most predominant in firstborn male. Doesn't have to be premature. It can be premature. It can be adequate gestational age, etc. Importantly, what is pyloric stenosis? Basically, the hypertrophy of that and hyperplasia of the muscles of the pylorus, which leads to a narrowing and the gastric antrum of the gastric antrum, which lead to a gastric outlet obstruction. The ultrasound is extremely sensitive and specific to pyloric stenosis. We're going to be looking for specific findings, which are the anterior muscular wall thickness more than 3 millimeters and a pyloric canal length of 40 millimeters with no evidence of peristalsis and little movement of stomach contents from the stomach to the duodenum. And this is very important because what it's showing is the presence of that gastric outlet obstruction that is going because of the pathology. We're going to be using the linear probe and a technique in which we're trying to keep the patient as supine when we're doing the evaluation. However, there is a good technique for doing this evaluation, which is basically don't give the kid food for the next hour or so before the study. When you're going to be doing the study, you're going to be rotating the kid towards his right hand side, kind of like a right lateral decubitus. Start feeding the kid. Put the probe in this position in which we're going to put it closer to the epigastric area, rotate it towards the shoulder, kind of like where you're doing a parasternal long axis view. And then when the child is being fed, you're going to be then slowly placing the patient from a lateral decubitus to a completely supine position and feeding at the same time, because what it does is that it displaces the pylorus towards your probe, and that way moves anteriorly and you get a better image. And we're going to be looking for an area. We're going to be doing all those techniques while at the same time try to do, if we find a little bit of interruption, a little bit of air, trying to do some graded compression of the kid. Like we're seeing over here, this is after right lateral decubitus. Now the kid is supine while we're trying to look for the ultrasound evaluating that area of the pylorus. So what are you going to be using as landmarks? You're going to be using the stomach, the liver, and the gallbladder as the main area that you're going to be doing the evaluation. And you're going to be looking for that entrance when we're feeding the kid of fluid towards the stomach, but it's not passing through the duodenum. This is the area that we want to see when we're doing this image. We got the liver, we got the gallbladder, and when the pylorus is going to be displacing anteriorly as you're feeding the kid and rotating it at the same time. We're going to be seeing, as I said, in the area of the liver, a little bit of the gallbladder closer here, and then pylorus over here with fluid presence in the stomach that is not passing towards the duodenum. Important thing is that once you get the area, once you identify the structure, you gotta measure it. And as I said before, the anterior wall of the pylorus is the one that we're gonna be measuring. It shouldn't measure more than 3 millimeters in size. And the canal has also to be measured, and it shouldn't be more than 14 millimeters in length. How are we gonna remember those numbers? Remember pi. Basically 3.14, not more than 3 millimeters of the diameter of the anterior wall, and not more than 14 millimeters in length. Sometimes because of the buildup of that pressure over the gastric mucosa, you may see what is called antral nipple sign, which is the placement of the mucosa in the area of pylorus towards the stomach because of the pressure that's generated by the closure of the by hypertrophy of the anterior of the pyloric walls. This was not the case of the patient, but this is a case over here of a patient that we identified with. You're evaluating the area where the anatomical structures include the liver, the stomach. You see over here the area of the pylorus, and you see the antral nipple sign over here moving towards the stomach. So that tells us that something is pressuring the mucosa towards it, and you see gastric contents of gastric contents not entering the area of the duodenum. Okay, last but not least, I'm going to be finishing up my presentation with a bonus slide over here. How many of you get frustrated when we don't get the pee when we're trying to do a urine cap? I'm one of those that gets frustrated. So we're gonna be using the ultrasound for it. How can we use the ultrasound when we're trying to do a urine cat? Two things we need. We need the ultrasound, and please get a urine culture base, because if the kid starts being good, that's good. You're gonna have a clean catch over there. But the thing is that we're gonna be using the probe in a transverse fashion over the pubic area, and what we're gonna try to see is we're gonna measure it. If it measures from 2 to 4 centimeters, gives you a high likelihood that we're gonna catch some urine. But if less than 2 centimeters of size, odds are we're gonna fail. Just give the kid some time, like 30 minutes, rehydrate it. If you're having the kid being rehydrated, just do that, feed them, and then catch them once it's more than 2 centimeters. But as I said before, when you're doing the ultrasound, get something to collect the urine, because sometimes they pee on you, and that's a good catch and it counts. Okay? So I've finished my presentation on time. Does anybody have any questions for me